COPD, or chronic obstructive pulmonary disease, causes an enormous burden on healthcare systems globally. Despite it being a debilitating disease which leads to significant morbidity, mortality and disability, it's widely underdiagnosed and undertreated. This is unacceptable because it is a progressive and irreversible condition. The key is to diagnose and intervene early, and that is why researchers are investigating the precursor stages of this condition, commonly called pre-COPD. This is EUFOREA News. Hello and welcome to EUFOREA News. I'm Dr. David Bull. In an attempt to diagnose and intervene much earlier in cases of COPD, researchers introduced the term pre-COPD to define those patients who are at high risk of developing airflow obstruction. It was suggested that the term pre-COPD should be used in an analogous way to other pre-disease states such as pre-diabetes or preeclampsia. But to be effective, it is paramount that there is a clear operational definition of what pre-COPD is, how it's measured, and how it is defined. It is vital to assess whether the benefits of using such a new label outweigh the costs of more complexity for physicians, and that will rely on having clear scientific evidence. Well, joining me now to discuss all of the above is Professor Dr. Frederik Trinkmann. He is Senior Physician in Pneumology and Deputy Head of Pneumology and Critical Care Medicine at the University of Heidelberg in Germany. It's really good to talk to you, Professor. Let's start right at the beginning, if I may, with this term pre-COPD. How would you define pre-COPD?
Yeah, thanks for having me, and it's a great pleasure to talk about this really important topic that addresses early disease origin of COPD. And the term pre-COPD itself, it's not that well defined. In the end, there's a lot of research going on, but I think for now you can narrow it down to like three things. So pre-COPD, these are considered to be persons that still have normal spirometry but show clinical signs of COPD that may include, for example, dyspnea or cough. Then you have another finding that is referred to early disease that is called PRISM. This is preserved ratio impaired spirometry, and I think we can discuss later why this is or can be important to distinguish. And that adds to a concept we left and had earlier in the GOLD document, which is our global recommendation when talking about COPD. This was this GOLD 0 state. So we have like 4 spirometric states of impairment, 1 to 4 GOLD. And we have this GOLD 0 or have had, that's better, this GOLD 0 stage, which exactly addresses these subjects that are not patients yet, but which may suffer from some early diseases or disease stages. So it's not a perfectly designed or defined concept yet, but it's really important, I think, to have these early stages also in mind in terms of interventions we could perform.
I mean, this is what I found quite interesting reading about pre-COPD was, as you say, this is very much in the infancy. They're not exactly defined clinical criteria. You talk there about spirometry, about FEV1 and so on. Is this a moving feast at the moment? Is this something that is being constantly refined to decide who exactly has pre-COPD?
Yeah, there's indeed a lot of research going on, not also in terms of the definition of the state itself, but also in the devices we can use to determine these early stages, because we've learned that many of the measures we are using, and that mainly includes spirometry on a global basis, is rather insensitive for these early changes, which is just because it reflects more of the central airways. And the disease, it starts in the lung periphery, in the peripheral small airways below 2 millimeters of diameter. And it's important to also investigate methods that are capable of addressing and measuring these changes correctly. Also, imaging is a big thing in this field, and there's evolving data and a lot of things going on at the moment that not only addresses like the definition of the state, but also of the measurement techniques that we can use.
And I assume that the importance of having this condition of pre-COPD is that you find those patients much earlier, you can intervene much earlier, and therefore they do better in terms of clinical outcome.
Yeah, this would be the concept and behind it indeed, and our great hope, because at the moment we're diagnosing COPD rather late. So there had been a great paper, the Lancet Commission statement, which addresses this topic really well. And the basic problem we have at the moment, or a challenge, is that we're diagnosing COPD in patients like 50 or 60 years old, and the studies mostly include patients in these age ranges. But we know that the lung function impairment and the damage we have in the lungs, that starts way earlier. That starts within your like 30s or 40s, and that may be accelerated by things you do. For example, smoking in Western European countries. That's one of the major triggers, of course, but also in-house cooking, indoor cooking, or air pollution that can be really important triggers. And so there's a lot of space for earlier intervention that may even prevent COPD. And this is why it's so important, again, to have these early stages also in mind.
I mean, so that's really fascinating. So essentially, you're looking for those known risk factors, whether it is, say, smoking or the others that you mention. Those then give you a high index of suspicion, and therefore you are more likely to think about pre-COPD. Have I read that correctly?
Yeah, that would be the concept behind it. It will give us more opportunities to intervene.
So how exactly do you envisage using this label like pre-COPD in clinical practice? Because obviously these patients present to a multitude of physicians, whether it's in primary care or secondary care or tertiary care. How do you imagine this would be rolled out, and how does it become useful?
So at the moment we have like one major challenge in clinical practice that will impair a broader application of the concept. That is the diagnostic insensitivity of the tests we have. So we have room for improvement there. This is the one thing. And the other thing is that we only have little knowledge about like the long-term courses of these states. So how will they develop? Will everybody with impairment develop COPD in the end? For the gold zero stages, for example, this was not shown. This is why we left the concept. Not all of these gold zero patients turned out to be COPD patients. In the end, this is the first thing. We have diagnostic challenges in that. And the second thing is we don't have literally any data that is showing any intervention, a pharmacological intervention that would be helpful in these early stages, which again is based partly on the problem I addressed in the diagnostic and also in the definition part of pre-COPD.
So what about comorbidities like asthma or cardiovascular disease, for example? How do they sort of influence the progression of pre-COPD to COPD?
Yeah, those are two really interesting comorbidities. First, because they are frequent and they can be really complicated. Maybe to start with asthma, and we've learned that in a lot of therapies now we used in asthma treatment that are now available or will become available also for COPD. And there's a big overlap, huge overlap between asthma and COPD because both are obstructive lung diseases. They differ in the pathophysiology, of course, and in clinical aspects, but you can have both diseases in the same patient. And it's interesting because, for example, I see some asthma patients who report that they had allergies and an asthma diagnosis when they were adolescents or even younger. And then it got better in their young adulthood. And then they started smoking at some time or had another lifestyle changes, air pollution, and so on. And in the end, they turn out, when they present in our clinic at age 50 or so, they present with a picture that has aspects of both diseases, so COPD and asthma. That can be really hard to diagnose, first thing. And also the treatment can be complicated. And these are cases where both diseases will occur in one and the same patient. And it can be really hard to distinguish or impossible even with the techniques we have today. So that's asthma. Cardiovascular disease, that's another big thing, and that's even more complicated because you have a huge overlap in risk factors. So smoking, that causes both diseases, of course, but there's a lot more, like hyperinflation, for example, inflammatory states, and so on. And cardiovascular disease, this is one thing we should always have in mind, are the most frequent comorbidities in COPD patients. And that's a problem because this is associated not only with morbidity, but also with mortality. So patients with COPD, with concomitant cardiovascular disease, they have more frequent events, heart attacks, for example, and they also occur earlier. This is one side of the medal. And the other is that when you had, for example, acute exacerbations, so attacks of the lung that lead to deterioration of your lung function and quality of life, this happens all of a sudden. These events for COPD, they are traumatical. And these are associated with increased risk for cardiovascular events. So we have really strong data today that when you get hospitalized because of a COPD exacerbation, so a worsening of COPD, then this leads to a 1-year increase of your risk for cardiovascular events. So for example, stroke or a heart attack.
Now, right at the beginning, you talked about a lot of research going into defining pre-COPD. Just in terms of the broader picture, where are we in terms of having some sort of broad consensus between clinicians about the usefulness of this pre-COPD and the definition of that and the rollout of that across all medical modalities?
I think for the time being, it would be fair to say that I think most clinicians in pulmonology are aware, as it is in other disciplines, you mentioned that prevention is one really key thing for healthier life, longer life, and so on. Prevention is key. And so early detection, it's not debated by many people, will be helpful. This is the one side. But on the other, we have to admit, and this is the second part of the question in terms of like clinical adaptation of the concept, we have to derive measures from that. So it's good to have a definition, which we're working on, of course, and to reach consensus in this, which is already complicated, but we also need data and measures that we can derive. Just to make an example from cardiology, so for a long time, it was cool to smoke, right? Until the end of the last century, it was really cool to smoke, and it did take a long time to understand all the negative effects, which are still neglected by some people, of course. But I think it's undisputed that smoking is not healthy. And then we learned a lot, and we introduced a lot of measures in terms of passive smoke, for example, or making smoking unattractive. And this has direct impact on your cardiac health. And this is a good example and something that I would hope, and I think we can learn also in pulmonology, to have these measures that are based on the preventive things we can achieve when having a definition and solid diagnosis of these early stages.
So just looking forward, and finally, if I may just ask you, just looking forward in terms of the adoption or the widespread adoption of this terminology of pre-COPD, and I'm thinking particularly actually about primary care, general practice, and getting the GPs, those primary care physicians, to embrace this terminology. How do you think this is going to sort of roll out going forward? What are your hopes? What are your aspirations?
So my hope as a respiratory physician, and I wanted to become a cardiovascular physician, frankly. So my hope and learning from that would be that we get better political awareness, also scientific awareness, and also patient awareness, that lung health would be important. And there had been like a really impressive study last year from Canada, where they were just automated phone calls asking for symptoms, and this led to a considerable improvement when these these subjects were treated by a physician at least and a pulmonologist. But I think our task as a community, and especially as pulmonologists, would be to give these GPs, for example, also the devices and the knowledge and the definition to be able to screen these patients. And there are techniques available that are even easier to perform as compared to spirometry. Oscillometry, for example, that's way easier than spirometry, and these could be helpful, having a definition and measures we can derive to widen the awareness for a broad adaptation. And I think this is a sentence a colleague of mine is saying a lot, and I like that sentence really, that learning from cardiologists is winning. Because they had like a lot of like successful strategies implemented in these preventive measures and also in early diagnostics. So this is always a good thing to lean on. And when talking about a broader adaptation of the approach, we can learn a lot from that.
Well, thank you so much for your time. It's been a great pleasure to talk to you. Thank you very much to Professor Trinkmann.
Thanks for having me.
Well, that's it for this EUFOREA news, defining pre-COPD and its application in clinical practice. Now you can find more information about EUFOREA and also register for the EUFOREA educational events on the euphorea.eu website, where you can also sign up to receive the latest news via email. You can also follow EUFOREA on social media, on YouTube, X, LinkedIn, Spotify, Instagram and Facebook. Thank you for watching. Goodbye.